Hello, welcome. Good morning and good afternoon. Welcome to our session titled AI, Machine Learning, and the Future of Health Research Unlocking Insights with All of Us Data. I'm your moderator, Dr. Tawfiq Syed. I'm one of the PI of AIM Ahead program, and I'm also program director for AIM Ahead All of Us training program. I'm at UT Health Houston. Welcome again. We have put together a fantastic panel for you from the trainees from All of Us, AIM Ahead All of Us training program. We have a coach, and we also have a fantastic researcher out of UTMB, Dr. Surej Bhavnani, who's also presenting today. So let's get started. Before we jump in, a few housekeeping things. So this is a public event. Science Day is a public event. So this session is recorded. We'll have closed captions, and if you have any questions, technical issues, please reach out to this email you see on the screen. The closed captions we also have in both Spanish and English. So we have divided this session into two parts. The first part will have presentations from our fantastic panelists. In the second half, you'll have opportunity to ask us questions. We have a fantastic panel. So you see on the top Q&A, so feel free to ask your question. You don't have to wait till the end. Please go ahead and put your thinking caps and start thinking about the questions you have. We also have a chat, but if you have a question, please put that in Q&A, not in the chat. So let me quickly go over all of us, our program, AIM Ahead program. AIM Ahead is a large NIH-funded program. The goal of AIM Ahead program is to build AI workforce capacity and research infrastructure across all 50 states and territories. The goal here is to build our AI machine learning capacity in healthcare. AIM Ahead Coordinating Center is comprised of 4 cores. As you can see here, Leadership Core, Data Science Training Core, Data and Research Core, and Infrastructure Core. So in last 4 years, AIM Ahead has done tremendous progress. We have, in building our research and AI machine learning capacity in healthcare across the nation, we have given more than 200 research awards through various programs. As you can see, the reach of the program here and multiple programs we have built to build the research and infrastructure capacity across the nation. Similarly, our second goal is to build the workforce capacity across the nation. In last 4 years, we have trained more than 730 fellows and trainees using multiple different training programs and fellowship programs across the nation. One of such programs is a partnership between AIM Ahead and All of Us, including our fantastic partner, RTI. We have built a training program, and we have finished 2 cohorts, cohort 1 and cohort 2. Currently, cohort 3 is underway. This training program is designed to expand research in AI/ML, leveraging All of Us data and All of Us infrastructure, especially Researcher Workbench. In each cohort, we have selected 25 trainees, and we matched them with a mentor, and they went through intensive 8-month curriculum designed by RTI International and also our data science training core, including All of Us cohort development, machine learning modeling, Python and R programming. In cohort 3, we also started a genomics analysis track. And each of these trainees also get an $8,000 stipend, travel allowance to come to our annual meeting to present their work. This is, in all 3 years, we had overwhelming response to applications. As you can see here on the top, cohort 1, we had 214 applicants for 25 slots. And in cohort 2, we had almost 300 applicants for 25 slots. In cohort 3, we had 483 applicants competing for 25 slots. So we are very, very happy with the response we have received. As you can see, there is a huge need for AI workforce development capacity across the nation. So let me bring your attention to a free and open platform we have built called AIM Ahead Connect. And through this platform, we have made more than 80 courses on AI and machine learning and data science designed for healthcare, available to you as a free open source courses. You can enroll, it's free, you get a completion certificate. So far, we had more than 6,900 learners who enrolled in these courses, completed close to 10,000 modules. but we also building a community, a network of AI machine learning trainees and mentors, and we have built this research collaboration platform. So AIMHack Connect is a free open source platform that is available to you. You can join today. We have more than 10,000 AI machine learning researchers who joined our platform and leveraging it. You can network, you can connect, you can ask questions, you can join groups, you can take courses, you can apply for funding through AIMHack. So far, we have more than 6,700 trainees on our platform, more than 2,200 mentors and experts on this platform, made close to 8,000 mentoring connections. So looking back at our AIMHack and All of Us training program outcomes publications, you can see here in a snapshot, the cohort 1, we have about 12 peer-reviewed publications from our cohort 1 trainees that all have used All of Us data. So why AI is important in healthcare? We are just getting started. AI, I think, has a very high ceiling in what AI can do and how AI can help in healthcare space. As you know, already we have hundreds of use cases of AI applied to healthcare. I think within the next 5 to 10 years, we'll have thousands of use cases that can make both reduce clinician burden, increase our capacity to take care of our patients. If you see on the left-hand side, current state of how things are, a lot of data on a patient is very segregated, very siloed in different vendor systems, different platforms, different devices being used. All the data is very localized, is not all put together. So you can see with AI, the future state where doctors have more communication with patients, more time with the patients, all the things are happening in the background, right? So I have on the right-hand side few use cases, right? Application of AI in healthcare. Again, this is very few use cases. There are already hundreds of use cases, including medical diagnosis, including reducing errors in dosages, cancer research, personalized healthcare plans, health monitoring wearable that generates a lot of data. And All of Us has fantastic data on especially Fitbit and wearables. You will see more and more AI robot-assisted surgery. You will see AI in virtual nursing assistants and so on. We're already seeing multiple use cases in rare disease diagnostic treatment and so on, right? So we will have more and more use cases of AI. AI can help significantly in improving our patient care. So why this is important? How can AI impact healthcare? Let me start with the left-hand side. This slide here shows life expectancy versus healthcare expenditures in the last 2 decades. As you can see, we are right in the middle, right? It's very expensive. As you can see, compared to other developed nations and so on, the life expectancy is low, expenses are very high, right? So if you're not motivated so far, let's look at the slide on the right-hand side. The estimated market size of AI applications, AI research in healthcare is tremendous and is growing significantly. In 2025, 2026, the market is around $40 to $50 billion, but in next 5 years, it's going to quadruple to $180 billion to $200 billion. So if you are thinking of getting into AI, if you're thinking of data science, now is the time to jump in. And through AIMHack, through All of Us, you have tremendous amount of resources available to you to get started and make an impact. Next, I will introduce our next panelist. We have put together a great panel that showcases the use of All of Us data, the use of Researcher Workbench, and how AI can help figure out the insights and improve healthcare. Let me pass on to Dr. Suresh Bhavnani. Thank you.
Thank you so much for inviting me to give this talk on precision policies from All of Us data, which is a fantastic resource, to community impact. Many Americans have multiple non-medical drivers of health. Take, for example, Mary. Mary lives in a rural part of Texas, and she has breast cancer. And she's thinking, how do I get cancer treatment with no car or no healthcare insurance, because the clinic that she gets her treatment is in the city? These are problems that are called non-medical drivers of health, such as healthcare access and economic stability, both of which Mary is encountering. Unfortunately, current US policies do not really help Mary very well. This is because many of them target only single needs, for example, just addressing transportation problems, or are based on broad demographics. Such policies are just not precise enough to help Mary. So what we did was we accessed the All of Us data. We identified more than 44,000 cancer participants, just like Mary. And we extracted 110 of these variables that we call non-medical drivers of health, for example, lack of transportation. Then we use AI methods to analyze how the participants and variables group together. What we found was 4 groups of cancer participants. Each group had a specific combination of needs, and each group had different risks for depression. For example, this cluster, the purple cluster on the left, was named economic barriers because it dealt with low educational attainment, low literacy, low income, and not being employed. Whereas cluster 4 on the right-hand side, the gray cluster, was named cultural barriers because it contained language barrier, lack of healthcare coverage. What we found was, as one result, that if you belonged to cluster 1 on the left, you had a much higher risk for depression compared to cluster 4 on the right-hand side. Now, why does this matter? This matters because current policies, as said earlier, target single needs based on race and income. So, for example, transportation policy would target these very broad demographic categories. What we want to do with our AI research using All of Us data is to define more precise policies that we call precision policies. These policies would target combination of needs, just like what Mary has, based on her risk in each group. We use multiple AI methods for discovering such patterns, for interpreting such patterns, and then making predictions for future patients, and then translating them into real-world policies as well as tools to help people like Mary. We are developing human-centered AI tools to implement precision policies in collaboration with the Houston Health Department. So when Mary comes as a client to the Houston Health Department, she would work with a caseworker, and they would together interact with a tool called RAP, which stands for Referral and Access Precision Policy, which operationalizes the precision policies that are currently available. Such tools are expected to help clients like Mary to navigate the safety net, which have resources for her, but are very difficult to get because they target a single need at a time. Whereas this tool would enable Mary to access multiple needs to help her in her current situation. We're also translating the results through policy advocacy. I was a lead advocate on Capitol Hill for the responsible use of AI at the offices of Texas Senators John Cornyn and Ted Cruz. And I was honored to be a presidential leadership scholar last year, where I interacted with policy leaders such as Bill Clinton and George Bush on the concept of precision policies. This research would not have been possible without the data that's been provided by the participants of All of Us, and for the researchers that have spent so much time to make it available for researchers like me to really make a difference of translating AI into real world solutions. Thank you very much.
Thank you. Thank you so much. We'll move on to the next panelist. Dr. Wes Godfrey, please go ahead.
Hi, everyone. Thanks so much for having me. Today, I'm going to be talking to you briefly about some of the work that I did with the social determinants of health using all of us database, in particular eye disease. So just to give everyone a little bit of background, eye diseases like glaucoma can affect over 3 million Americans, and glaucoma, macular degeneration, and cataracts are going to be the leading causes of blindness in the US. And patient understanding that they have these conditions is important to make sure that they do the appropriate follow-up, but also get the appropriate treatments for these different diseases. So as we know, so in my research, one of the big questions that I asked was how people in the All of Us database knowledge of their eye disease was affected by different social determinants of health. And as we know, one of the really big strengths of All of Us is that it's just this huge database with EHR and survey data that's linked. So I tried to leverage that information to get a good idea of the different people who are in the All of Us database and whether or not they were answering yes or no to having these different eye diseases in their survey, and whether or not that was also true based on their EHR data. So as you can see here, we were able to identify many people with glaucoma, cataracts, and macular degeneration. But what was kind of interesting was looking at the different factors that were driving these patients' knowledge of their disease, or what I call EHR and survey discordance. So really what I'm looking at is, of the people who say yes on the survey that they have either glaucoma, cataracts, or macular degeneration, are these people also having clinical evidence of that disease as measured by EHR documentation? And looking at, I analyzed a lot of different factors that are associated with that. But some of the factors that I noticed were particularly prevalent was speaking a language other than English at home really had a large effect on the odds of that individual having this EHR survey discordance, particularly with macular degeneration and glaucoma, and not so much with cataracts. And that's potentially because people with cataracts are usually treated with surgery, and you know if you have surgery or not, but it's a little bit more nuanced to realize that you're taking this medication for your glaucoma, or rather you should be taking this medication for your glaucoma. And same with macular degeneration, there's a lot of follow-up, and some people are medically managed, some people aren't, but it's a little bit more nuanced to realize that you have that disease. Same with race and income as well. So kind of in my conclusions, I found that glaucoma had the highest rate of survey EHR discordance, while cataracts had the lowest level, probably because cataracts are treated with surgery. Everyone knows that they have a surgery, but it's a lot more nuanced. It takes a lot higher health literacy to realize they have a medical condition that's being treated with a medication. Higher income was associated with the lower odds of EHR survey discordance, which is making sense because the higher income, the more educated you likely are, and the easier it is to understand your different health conditions. Black race was associated with higher odds of discordance, while Asian race and no race were associated with lower odds of discordance, as well as male gender. So I think this research just kind of goes to highlight that this huge database in All of Us can be used to identify the different social determinants of health that affect people's knowledge of their disease. And then potentially we can target interventions at making sure that people from these groups who are less likely to realize that they have the disease appropriately realize that they have it so they can get the treatment that they need. Thank you.
Thank you. Thank you so much. Next, we will move on to Dr. Paloma Dos Santos. Please go ahead.
Hi, everybody. How are you today? Well, next, please. I'd like to talk about my work related to the quality of antenatal care and pregnancy outcomes. And we often measure antenatal care by many visits we have. And by that doesn't really tell us whether they receive the care they actually needed. So here I'm asking a simple question, but really important. It's not just how many visits women attend, but whether the quality of care is related to major pregnancy complications. In my study, I focused on two outcomes, gestational diabetes and preeclampsia. I used the data, the All of Us, and specifically EHR-based cohort or about 900 pregnancies. And because of how the data are collected, the sample includes more complex cases. And instead of focusing only the visit count, I define quality based on whether key components of care are actually delivered. And so the idea here is really straightforward. It's not just how often care happens, but what actually happens during those visits that may drive outcomes. So typically the idea is women who interact more with the healthcare system, women who had tests, diagnosis, follow-up, or other, often women with complications or high risk. And that's why I want to see the prevalence of gestational diabetes in preeclampsia, it's high. You can, next please. And how I defined the quality of antenatal care. And I combined both the content care and the number of visits following by WHO guidelines. And in EHR data, I focus on 6 core components that routinely capture the electronic health record, including the blood pressure, urine protein, HbA1c, ultrasound, the supplementation, and along with the women had at least 8 visits. And based on these, I classified the care in 3 levels. One is the high quality, means women received all the key components and had 8 or more visits. Intermediate means most of the care was there, but something was missing. And the low quality reflects clear gaps, either not enough visits or missing several parts of care. So this approach, what I did was moves beyond the visits and try to capture whether recommended care was actually delivered. Next, please. And also moving to the main findings first, I didn't find an association between the quality of prenatal care and gestational diabetes, but this is not entirely surprising since the gestational diabetes is largely driven by underlying metabolic risks. So what we are seeing is that care helps detect it early, but doesn't necessarily change whether it develops. And for preeclampsia, the patterns look a little bit different. We actually see lower recorded rates among women with low quality care, but this is unlikely to reflect a real protective effect. It's more likely that women receive more complete care, are monitored more closely, and so preeclampsia is simply more likely to be detected, right? In this view, now there are important distinctions here. Antenatal care helps us identify these conditions earlier, but doesn't necessarily change whether they develop at the first place. And when I looked by race, among Black women, those receiving intermediate quality of care had almost 4 times higher odds of gestational diabetes compared to those with high quality care. So even small gaps in care cease to matter here, especially for groups that are already at higher risk, likely because those gaps means missed change for earlier screening or follow-up. So the conclusion here, the antenatal care may not be prevented these conditions, but it helps us catch them and manage them. So making sure that the care is complete really matters, especially when we think about disparities. Thank you so much.
Thank you so much. Next, we'll move on to our Q&A session. I'd like to invite all our panelists. Thank you, Emma. I also want to introduce our panelists. We didn't get to hear Danielle Brannock. Dr. Brannock, if you can introduce yourself.
Sure, thank you. Yeah, so I'm Daniel Brannick. I'm a research data scientist at RTI International, and I am one of the coaches for the AIM Ahead program, in addition to being a researcher who has gotten a lot of use out of the All of Us Researcher Workbench. Thank you.
Thank you. Thank you so much. So Emma and Sydney, if we have any questions from our audience, we can start there. I see one question in the chat. Again, this is for all the panelists, so feel free to jump in. How are we keeping AI in medical research open and non-biased? Suresh, if you want to go first.
Yeah, sure. So first of all, the data collection step is really important. And the All of Us program tried very hard to overrepresent minorities that had not been reflected in many of the studies before. That's a foundational belief of the All of Us program. But then within the data itself, there can be missingness. Some people don't finish the surveys, etc. And so that second step, in terms of after they are recruited, often there is bias. And we pay very, very close attention to issues of bias, not only in terms of who finished the surveys and their data was complete, but also once we develop our own algorithms, we test whether those algorithms show any bias across the subgroups that we identify. So there's sort of almost 3 layers of addressing bias. First, from who do we call into the program, the participants that are so important. Second, do those participants complete the surveys, so they could be biased there. And third, in terms of the algorithms that we develop to make sure that they're not biased. Does that answer your question, Tawfiq?
Thank you. Thank you. Let me also ask for a few more perspectives. Paloma, do you want to chime in?
Yeah. Oh, so I think that AI models learn from the data we're giving them. Yeah. So definitely the data have biases. In their results, one of the challenges, especially that I face, the result will reflect those biases, and we also need to make sure that the models are interpretable. Now, especially in the healthcare research, is not enough to have a prediction, but we need to understand why that. And I think that from my perspective, you should avoid over-reliance on complex models when a simpler approach can answer the question. So transparency and clear interpretation are really important here.
Thank you. Thank you. So everyone on the call, feel free to ask us questions. Please drop your question in the chat. Don't wait till the end. Go ahead and drop your questions. Put your thinking hats on. We have a great panel. So while you're thinking, let me fill in a few questions. This is for Danielle. For people who are new to All of Us, what is special about this data?
Yeah, I love that question. And actually, I get to kind of answer the previous question too at the same time, which is one of the things that's really powerful about this data is that it's as accessible as it is. So that relates back to how we keep medical research open and non-biased. One of those ways is by allowing it to be reproducible. And because this data is accessible to anyone at one of the institutions that has a DUA, anybody can go in and evaluate for themselves. Is this work responsible? Is this work reproducible? Is it biased in a way that might impact me or the people that I am interested in? So I think that's a really important piece of this, is that you can collaborate across institutions and everyone can see the same data at the same time. And then once a study has been published, you can publish that workspace and anybody can then reproduce that study even years down the line. So I think that's a really powerful part of this program that maybe doesn't get enough attention.
Thank you. Thank you. This is for Wes. For your study or for your future studies using all of us data, how did you decide what health condition, behavior, or outcome your project would study? Like, how did you come up with, this is what I want to do, this is what I want to study?
How did I come up to do with my particular diseases of interest? I think that was driven by when I see patients in, I've seen patients in clinic, the differences in the glaucoma patient population versus say cataract patient populations was rather remarkable. Glaucoma also does tend to affect people with who are socially disadvantaged from a health perspective. And really, I was kind of interested in using All of Us. I was part of the AIM Ahead program and learning how we can use this giant database to try to advance health. And that's what made me pick the disease that I did. I think that these diseases are replicable across many different health conditions. I'm trying to work with other trainees right now to get them to look at social determinants of health in X, Y, or Z disease. But I think really the strength of All of Us is the large database and the fact that we have such a diverse population.
Great, thank you, thank you. So I have one question for all of you actually. So feel free to raise your hand. Typically, when we do a study outside of All of Us, we pick one clinic. We have access to one hospital system. So how does having access to multiple healthcare systems, multiple clinics across the country help with your study? Like what was the impact? Maybe Paloma, if you can start.
Yeah, so in my study specifically, my first project in AIM Ahead, when I was in my cohort 2, I did not directly compare the All of Us with other cohort, but even though I have worked extensively with data sets like PRAMS and DHS is Demographic Health Service, but having the background helped me to interpret my findings. Now, for example, when I compare to population-based data sets, like PRAMS or births, All of Us reflects a more clinically complex group since it's based on electronic health record that I used a lot, and also people interacting with the healthcare system. So it helps explain why we see, in my case, how I saw a higher rates of conditions like gestational diabetes and preeclampsia in this sample, and I didn't find in a population-based data set like PRAMS. So it's interesting how different data could give us not different outcomes, but the way we see. And having this background in maternal child health during my PhD, worked with those global health data across different countries, and I kept noticing the same pattern when I measured, for example, the quality of antenatal care. That's why All of Us, I saw this opportunity to use this real world clinical data here in the US and also look at disparities across those groups.
Thank you, thank you. Suresh, if you want to add to that.
Yes, absolutely. So before All of Us, most of the non-medical drivers of health studies were done within hospitals. So they were very small sample size, and you just cannot generalize across populations with such a small sample size. So when All of Us made these data available, we were so excited. Like, this was the first time we had this massive trove of 110 variables that we could analyze. And, machine learning and deep learning requires lots of data, and so not only could we generalize our results because it represented all of America, but it also enabled us to do a lot of learning, through our models. So it's essentially transformed my lab and my entire career, because I could take these results to the Presidential Leadership Scholar Program and not say that I'm just using data from UTMB or some other place, right? I could say this represents our entire country, right? And these patterns are who we are. And we need to address the policies to help people like Mary. So it was, a breakthrough from a data point of view, because we could make these very broad claims right at the level, at the presidential level. And they listened because we had the data.
Yeah, thank you. Next, we'll move on to some audience questions. Thank you for adding questions. Feel free to add more questions. Let me start with the first one. This is for Dr. Suresh. The clusters clarified by Dr. Ravnani looks great. I would like to know how many factors included in the cluster analysis and how these factors were selected. I know this is a very specific question. don't need to put you on spot.
No, I would love to, because we spend so much time, all the researchers on this panel are great, and all of them probably know that 80% of your time goes in cleaning up the data, right? It takes so much time to get your data so that it's statistically and, logically correct. So we started with 110 variables across 4 surveys that all of us provided, right? So we had a panel of human beings, experts, who looked at manually all of these 4 surveys, and then they came to a consensus that these were the 110 variables that were critical if we wanted to study non-medical drivers of health. But when we went into those 110 variables, many of them were not independent, because, in machine learning models, you need variables that are independent. So if someone said, for example, I don't have money for healthcare insurance, and then you ask them another question, do you have dental healthcare insurance? Those are very related to each other. If you don't have one, most probably you don't have the other, right? They're not independent. And so we had to then do another phase of stakeholder consensus by going through the 110 variables and then reducing them so that they were independent. Now we are thinking about how to doing that whole process automatically, but as the first phase, we wanted high accuracy, high precision, and so we did it manually. But that is an excellent question. So ultimately, from the 110 variables, we boiled down to 18 factors, as we call them, and we did the cluster analysis on those factors and all the other downstream learning that happened. Sorry for the detailed answer.
Thank you. The next question is a fantastic question. I don't know if we have a complete answer for that, but I want to, Wes, if you want to, go for this one. The question is, I don't know if you can see, let me know. This is about rare disease and genomic analysis. Thank you, Dale, for putting a lot of details in here. Go ahead, Dr. Wes.
Can you repeat the question just for everyone?
So thank you. At some point, AI may be, I'm paraphrasing it, at some point AI may be able to help with drug and treatment selection for those with rarer conditions. In this case, we have a specific gene detected, using all of us, process. And the question is, how far is AI from actually telling us which medications are more appropriate? Like, we're also talking about gene editing and so on. There's a lot of things happening, like CRISPR technology and, specific medication and so on. How far is AI from connecting medications and procedures and processes with the detection of certain gene markers?
I think that's a great question, and honestly something that could be a whole hour-long discussion in and of itself. But just to give you a short answer, as far as genomic data is concerned, genomic data and whole genome sequencing is increasingly being incorporated into the clinical space. However, its utility is a little bit more variable, because really what we want to focus on with genomic data is gene modifications that are known to cause disease, and those are very easy to are much more actionable by a clinician. The problem with genomic data is that sometimes we don't always know what to do with it, and that can lead to difficulties for a clinician to make the appropriate medical decision. And oftentimes we just ignore it because we just don't know what to do with it, Or we even tell people, just don't order this test because you don't ever want to have information as a doctor that you don't know what to do with. And then as far as AI making treatment decisions or deciding what medication is best, I would say that most of the time, the way medicine works is we have a first line, a second line, a third line, etc. And the reason why this medication is the one that we try first has usually to do with side effect profiles, efficacy, or cost as the three big things. So we don't necessarily need AI to tell us you should try this one first if we already have a lot of really great reasons as to why this patient should try it first. Medicine is also just very complex, and asking AI to take over the job of a physician is something that may happen, but right now is just a big task. One last thing as I'll leave you, there was recently a Nature Medicine paper where they tested how well an average user could use AI to diagnose their medical condition. And the results were actually really poor, which tells us that most of the general public can't use AI to diagnose their medical condition like a doctor could, because they don't know what information to feed into the AI model. But a doctor knows exactly what's important, what's not important, and then can make decisions appropriately.
Thank you so much. Let me share the next one with Danielle, and anybody else, and feel free to chime in after. So as AI continues to advance research, healthcare research, what are the most important opportunities and challenges ensuring that AI-driven discoveries truly benefit all populations, especially for chronic conditions like Alzheimer's?
Yeah, it's a great question, and it's one of the reasons that I'm really excited about this data set. If you go looking in the literature for how All of Us is being used, you'll see a lot of primary research, but you'll also see a lot of instances where research has been done previously on homogeneous data sets that really just had one group of people, predominantly those of European ancestry. And that is now being challenged and validated against a much more diverse sample that's represented by All of Us. So I think this data set does present a unique opportunity to address this exact concern, which is how do we make it useful for everybody? Well, we've got a lot of research that's already been done that needs to be checked again with a more diverse group, and All of Us lets you do that. And for the chronic conditions piece especially, I think this is a really interesting area because All of Us has data on a lot of people, but something else that it has is data going back a long time. Not for everybody, but for quite a few individuals, we have data going back decades, EHRs going back decades. And so if you're trying to evaluate chronic conditions and you want to evaluate that over a long span of time, that's often hard to do in other data sorts. I've worked in a lot of data repositories that only have data going back the last 5 years, whereas this data can go back, for some individuals, back to the 80s. And so if you're trying to evaluate long-term chronic health problems, you need that long history, and this can be incredibly powerful for that purpose.
Thank you. Next one is for Suresh. How do you envision AI shaping the future of health research in the next 5-10 years, especially ensuring equitable outcomes?
We've covered some of those points. I truly believe that all of us, not just the participants, but also the researchers, we should start putting a lot more focus on the translational aspect, right? Because when I started talking to the Houston Health Department, my God, it was like an eye-opening experience. I had spent so much time thinking, oh, I'm going to build these models that are going to be more precise than you've ever seen before. And then you talk to the deputy director of the Houston Health Department and says, Suresh, we don't really care about precision as much as we care about recall. Because when Mary comes to our office, correct, she may never come back again. And so if the models that we design are super accurate and eliminate Mary, right, because precision and recall tends to be a trade-off, right? So if you're very afraid about, for example, having a lot of false positives, correct, then you want to be very precise, but Mary may never come back. So from her point of view, it is okay to be a little bit wrong as long as you grab as many people as possible in the first encounter. And that just exploded in my mind, because to me, precision and recall was just a number. It was like 0.5, all these packages in R and Python, they just put a default number in there and then we go with that. But we have to carefully think that when we are talking about models that impact real people in public health, in the clinic, what are the real problems that they are facing? Do they really care about this high precision? These 2 points of precision improvements that we are getting in our models, is that really important? And I'm realizing that there are a whole lot of other very important issues that researchers like us tend to ignore. And if we start talking and thinking about the real world problems and then back into our models, we will have a much higher impact than just trying to improve our models on their own. That, to me, is the lesson that I've learned using the All of Us data and working with the Houston Health Department.
Thank you. Thank you so much. I think we are almost out of time. So let me ask one last question to Wes. What should we be careful about when using AI in healthcare?
I think that is, I remember there was at AIMAHEAD talk, a researcher talking about some of the really great applications of AI, such as triage or doing parts of a doctor's job that they really don't like. And I think that we should just make sure that any AI research is congruent with the reality, and making sure that we make AI accessible for everyone, but also make healthcare work better, as opposed to trying to go against the grain too much, especially in the early phases of AI adaptation.
Thank you. Thank you so much.
Talk to your end users.
Yes, yes.
Talk to the participants. Talk to the physicians. Watch how they actually do the work, because then we have a shot at our results being actually useful to the world.
Well said. Well said. Anybody else wants to share any last minute insights?
Yeah, I do agree that we also need to be careful about overtrusting the technology. AI should support decisions, not replace clinical judgment. And also the transparencies. Clinicians, patients need to understand how decisions are made. And also you have to make sure that AI is actually useful in real world settings, not just accurate for research. So being also practical and accessible for different populations is a really important mission here.
Thank you. Thank you so much. I also want to shout out All of Us team for doing tremendous job. This has been a big lift, and I want to thank the entire team behind it, not just for organizing the Science Day, but doing the All of Us project. This is a monumental effort, and I want to thank everyone who's part of this, because my trainees are utilizing this. It's changing their life. It's changing, and we want to change our healthcare. We want to enhance it. We want to make it better for our patients, for our clinicians, for our nurses. And I think starting with the data, there's no AI without data. So I think having access to this large data has changed a lot of things for us. So I want to thank the All of Us team. Thank you everyone on this panel. Suresh, Paloma, Wes, Danielle, thank you so much for your time and insight. This has been fun, engaging session. And I also thank the team behind the effort, Emma, Sydney, and Susanna, everyone. Thank you so much for organizing this. With that, I wish everyone who participated have a wonderful week, and thank you for your time.